Okay, we will continue with cardiovascular modules, and this time we will talk about heart failure. Now let's make things simple. The heart has two functions. The first one is to receive the blood. And as you know, left ventricles receive the oxygenated or the rich oxygenated blood that comes from the lung, goes to the right, to the left atrium, then to the left ventricle, and then the left ventricle will push it to the rest of the body, and the right ventricle receives the oxygen, which is the poor oxygenated blood that comes from the rest of the body, and again then it will be pushed to the pulmonary circulation where gas exchange takes place. So ventricles, this period of or function of receiving blood takes place during the diastole. So the ventricles, they need to relax to receive enough blood, enough to maintain a normal cardiac circulation. So during diastole, ventricles should relax to receive more or enough blood. Now the other option is to push the blood, and as you know, the left ventricle pushes the rich oxygenated blood that comes from the lungs to the rest of the body, while the right ventricle pushes the poor oxygenated blood to the lungs to be oxygenated. So during this period of systole, the ventricles need to be strong. Okay, the muscles should be normal and the wall should be strong enough to push the blood. So this is the time where the ventricles need to push. Now for the pathophysiology, again, heart failure means that the heart is failing to perform one of both or both of the functions that we just talked about. So when the heart fails to receive enough blood, which takes place during diastole, that's what we call diastolic heart failure. Remember, we say the ventricles should relax during this time to receive enough blood. Enough blood is required to have a normal cardiac output. So this is my words just to help you understand the pathophysiology. So I'm talking to the ventricles right now. If you don't relax, you won't get the max, and by the max here I am referring to the blood return. And if you hypertrophy, your pressure is high sky or sky high, and that's again when the ventricles don't relax during the diastole and they become thick. When the wall becomes thick, then the pressure inside will increase. So you've become thick, so that's referred to the thickness of the wall. Well, your owner is sick. So that means that the patients will start to show symptoms when their wall, the thickness of their wall is increased, and that's what we call by hypertrophy. So this is classically what the diastolic heart failure presentation. So this is a normal heart, and this is what happened during the diastolic heart failure. As you see, you can see the thickness of the wall. Now you can see that the size of the chamber will change as a result of this increase in the wall thickness. In the other side, it's the heart failure regarding pushing enough blood. So the pushing, as you know, of blood takes place during systolic period. So this was called systolic heart failure. So we're speaking again to the ventricles. If you become thin, so now the pathophysiology here for the systolic heart failure is that the wall of the ventricles become thin. If you become thin, you will never win. And we will talk about the compensation, as a compensatory mechanism, how the cell wall or the wall thickness become thin. And you become weak. So if you become thin, you will never win, or you will not win. And you become weak, so you won't peak. And what I mean by peak here, I'm referring to the ejection fraction. In the systolic heart failure, the hallmark and the highlight is the abnormal or subnormal ejection fraction. So again, if you become thin, you will not win, and you become weak, so you won't peak. Instead, you will leak. And by leak here, I'm referring to the I'm referring to the pulmonary edema, the leak of fluids in the pulmonary edema as a result of increased pressure in the left side of the heart. With an echo, we will take a peek. We will use an echo to look at the heart structure during heart failure. Your wall look like a freak. Now the wall is very thin and your ejection is bleak. So now here's where the ejection fraction is low. Okay. Now this is again a normal heart, and this is what happened during left ventricular hypertrophy. As you see, the wall thickness is very thin right now, and that's why the systolic heart failure is very low. Okay. Speaking of the etiology, the two major risk factors that we've seen in patients with heart failure is number one, aging, and number two is having coronary artery disease and mainly myocardial infarction, history of myocardial infarction. Now there are other types or other risk factors. They're not as significant, but these are the factors that you can see also in patients with heart failure. Okay. Now there are two types of heart failure, as you see: systolic heart failure and diastolic heart failure. Systolic, the failing of the pushing of the blood, and diastolic is failing to receive enough blood again. So in systolic heart failure, again, it could be an MI, hypertension, aging. These are risk factors that's led to a heart failure. And what happens again in systolic, the walls of the ventricles become very thin and weak, so won't be able to squeeze enough and to push enough blood. As a result of that, there will be low cardiac output and low ejection fraction, and that's the highlight of systolic heart failure is low ejection fraction. As you know, ejection fraction normally it's between 50% to 70%. And again, ejection fraction is a percentage of the blood that the ventricle will eject, percentage of the blood that they will eject out of the total amount that they receive. In diastolic heart failure, could be the same manifestation, it could be the same risk factors, but here what happens is the wall thickness increases here. So now the ventricles, they receive less blood as a result of this hypertrophy. And because the systolic is reserved, because this problem mainly it has to do with the time of diastolic, then usually the ejection fraction is normal, because the wall are thick enough to push the blood, but because they are too thick, then the reception of the blood is low, or the received blood is low. Okay, another classification is left-sided versus right-sided. Now let me make this very clear. Most patients, when they start with left side heart failure, if it's not managed, or if the progression is not slowed down, they will develop right side heart failure. Okay, because remember, this is all connection. It's all circulation connected with each other. The left ventricle is connected to the right ventricle and so on. So the left ventricle is connected to the left atrium, connected to the pulmonary circulation, which is connected to the right ventricle, which is connected to the right atrium. So it's all one circulation. So when there's an increase in pressure in one area of this circulation, when there is a back up of or backflow of blood in one area, it will affect all the organs that are involved or the structure that are involved. So the most common, as I said, most common risk factors could be aging or hypertension or coronary artery disease, and mainly MI. So this may lead to a death of some cells of myocytes. So now, as a result of that, the muscles become weak. So the cardiac output that's leaving the left ventricle at this point is low. Now, this low cardiac output will trigger the mechanism of the body that is activated whenever there's a lack of perfusion as a result of low cardiac output. Now, these mechanisms, they attempt to maintain the cardiac output within normal, and they include tachycardia as a result of activation or increased stimulation from the mainly the sympathetic nervous system. So you know the relationship between cardiac output and heart rate and stroke volume. So increasing the heart rate should lead to increase the cardiac output. Also, the activation of renin-angiotensin aldosterone system, and you know this mechanism mainly maintain the cardiac output, or attempt to maintain the cardiac output by increasing the reabsorption, the water reabsorption. Also, the increased production of antidiuretic hormones that will decrease the diuresis, and so this way it will keep or maintain or increase the reabsorption of a fluid and cause fluid retention. Again, part of also the changes and the hormonal changes is that the ventricles will dilate in response to this high pressure that results from all of these mechanisms. Now, these mechanisms are they normally work. They attempt to maintain physiological stability. However, because the ventricles are sick already, or the ventricle here, left ventricle, because there are cells that are already dead, the extra pressure that comes from tachycardia and the extra pressure that comes from all this fluid reabsorption complicates the situation. So at that point, the ventricles will release the ANP and a BNP. We talked about this last time. These two peptides, they have contractory or they try to counteract this mechanism. The ANP and PNP, they have a vasodilation effect. They try to relax the blood vessels, decrease the afterload, so they try to make it easier for the ventricles to push the blood. Now, if this get complicated and then the mechanism, they don't work together, then the left ventricle and shape and function will change as a result of the continue or a progression of the problem. So as a result of that, the myocytes in the left ventricle will hypertrophy. Now, when that happens, you know that the thickness of the wall will change in left-sided heart failure mainly. If it's systolic, as we say here, then the wall will become thin. When the wall becomes thin, then again the muscles are even weaker and the cardiac output even lower. If the thickness increases and now the ventricles the pressure inside the ventricle will be even higher. So that high pressure in the left ventricle will travel to the left atrium and increase the pressure there, which is connected to the pulmonary circulation, and mainly what we call the pulmonary artery wedge pressure, which is the pressure in the pulmonary capillaries. When that pressure increases, the fluid will move from the serum or from the blood, from the circulation, to the alveoli, and that leads to a pulmonary edema, which is the highlight of left-sided heart failure. Left-sided heart failure, because the left side is connected directly to the pulmonary circulation, and because the blood or the pressure backs up that way, most symptoms of left-sided heart failure are of a pulmonary origin. So you see pulmonary edema, dyspnea, shortness of breath, mainly these are the symptoms of left-sided heart failure. Again, if the pressure continues to move, it will move from the pulmonary circulation back to the right side of the heart, and that's how the left-sided heart failure end up become also right-sided heart failure, and we get a mixed heart failure, right and left ventricles. On the other side, the right-sided heart failure, again, this could be just a complication of left-sided heart failure, as I just said. Again, the same idea. The pressure inside the right ventricle will increase and will travel back to the right atrium. And when the pressure increases in right atrium, the pressure also will increase in the circulation, in all the venous system. So that increase in the blood pressure in the venous system, like in the vena cava and the jugular veins and the peripheral veins, will lead to edema. This time the edema will be peripheral edema. So this is one of the major difference. This is one of the major difference between right-sided versus left-sided heart failure. The left-sided heart failure mainly a patient will show pulmonary symptoms because of the pulmonary edema. However, in the right-sided, it will be the peripheral edema, hepatomegaly, splenomegaly, JVD. So mainly the symptoms will be more of a systematic and peripheral and venous congestion. As far as the chronic and acute, again, the heart failure is not a disease, it's more of ventricular dysfunction, so it has a syndrome or a group of symptoms. As a lot of patients, they manage, they take their medication, they if they do restriction of their fluids and salt, they will live with chronic heart failure. Now, at one point, the chronic heart failure will have some acute episodes, or called acute decompensated heart failure, and that's when the patient needs to be admitted, and that's usually when the management fails or the patient developed new symptom, or the patient fails to adhere to their medication, and so on. So you definitely, as far as a chronic heart failure, you need to give a lot of education. It's a major problem. We need to continue to give education for patients to make sure that they don't get hospitalized or try to decrease the admission rate. But what you will see in the acute settings, mainly again the patient when they come to in diagnosis we call acute decompensated heart failure, which means that the compensation failing, and now the patient has some serious complication or serious symptoms and need to be hospitalized for management. Now, there are 4 different terms or groups, depends on the severity and the symptoms of the heart failure. What you may hear, as you see in the book, is dry and warm and wet and cold. So simply, dry refers to there's no edema, there's no fluid, patient is dry. And warm means that there's enough perfusion. Cold means there's poor perfusion, and wet means there's edema. So when you get it this way, you will see that the worst case when the patient has wet, cold heart failure. Wet means that the patient is overloaded and there's edema, could be peripheral, could be pulmonary, and cold means that the cardiac output is low, so there's low perfusion. The dry warm, that's when the patient has no fluid. Usually the patient doesn't have any symptoms when it's dry warm. Again, as well as warm means that there's good perfusion, and dry means there's no fluid overload. So just understand the difference here. But if you have 4 different patients with these descriptions, and 4 of them they have heart failure, and you're looking to see which one should you see first, or if the question asks you about priorities, you're going to first see somebody who has a poor perfusion as well as a fluid overload, because that's the more severe case. Okay, so now we understand the etiology. Now we understand what is expected to find in the history of this patient. And so, as you see, patients usually just their age. Age is a major factor now. The statistics states that patients who are older than 65 years old, the rate of heart failure is almost 1%. So again, diabetes can cause that, radiation, chemotherapy, drug abuse, all these are risk factors. Now, in physical examination, again, heart failure could be right-sided heart failure or left-sided heart failure. We say that right-sided heart failure mainly has to do with the peripheral increase or peripheral congestion. So the patient, ascites, which is basically abdominal edema, increase in the liver size, again because it's connected through the portal circulation to the right side of the heart, peripheral edema, JVD, splenoedema, and weight gain. Now, mental changes in digestion are also common, but these what will really distinguish the right-sided heart failure. The left-sided heart failure on the other side, you see pulmonary edema, dyspnea, orthopnea, tachypnea. As you see, mainly are pulmonary symptoms: cough, crackles, dislocated PMI, point of maximum and impulse, and the rest they may share it with the right-sided. So if you have a patient with mixed heart failure, which means maybe the patient started with left, now they have right, you may see a mixture of these symptoms. Now, again, this is just a quick picture of the symptoms that you may expect to see in a patient with heart failure. Now, let's just comprehend some of these symptoms. Again, just a reminder. Now, when the heart is failing and then there's low cardiac output, cardiac output means a blood perfusion, oxygenated blood perfusion. So if there's low oxygen, there's low energy, the cells will not be able to receive enough nutrients and oxygen. So as a result of that, the patient will have fatigue. And fatigue is a subjective data, but the common description, for example, for this patient, they say they can't climb stairs, or they have to take a break every time they walk about a block. They need frequent breaks, and so on. The other one is the dyspnea and pulmonary edema. Again, when the heart is weak, the left ventricle hypertrophy, increase the pressure. That pressure travels to the pulmonary circulation. When the pressure increases in the pulmonary circulation, then the serum will leak, and so the fluid will move from the blood to the alveoli, so the alveoli are drowning, and now there will be poor gas exchange, so there's less oxygenated, and that's why the patient feels the dyspnea. The other type is the peripheral edema. Again, the increase in pressure in the right side of the heart will travel to the vena cava, to the jugular, to the hepatic, to the spleno, and to the peripheral veins, and as a result of increased pressure and congestion in these blood vessels, then the blood or the water will move from the blood vessels to the interstitial, and that can lead to edema. The other symptom is called the paroxysmal nocturnal dyspnea. So basically, this is when the patient during the day they are standing. The edema is dependent, and because of the gravity, it stays away from the heart or from the lungs mainly. When the patient goes to bed to sleep, because of this position, the edema, the peripheral edema now, because again of the gravity, starts going back. It's become easier for it to go back and go to the right side of the heart, and from the right side of the heart to the pulmonary circulation, and that increases the pressure in the pulmonary circulation, which could be already high because of the left side of the heart, left-sided heart failure, and so that increases the pressure, and that will increase the pulmonary edema, and that's why the patient woke up feeling like they are suffocating or like they are drowning. Again, because of this position that the patient assumes at night, and that's increased. So if that happens, now any of these symptoms, if they happen, the patient should call their physician or should go to ER, because they're all an indication of that decompensated heart failure. So the patient should be seen. Okay, so this is not the time where the patient would just need to put pillows. This is the time the patient needs to contact their physicians. Now, there's another classification based on the severity of the symptoms. There's mainly two classifications. We have the New York Heart Association functional statement. We have classes 1 through 4, and we have the American College of Cardiology and American Heart Association stages. They have it A through D. So these are, again, they're subjective. If you look at it, this is basic class 1, no limitation of physical activity. Ordinary physical activity does not cause fatigue, dyspnea, so that's called stage 1. And then as the symptoms gets worse and worse, then we move. So what I want you to know is that stage 1 is not as bad as 2, and 4 is the worst. If you see stage 4, unable to carry any activity without discomfort, that's when the patient, now this is stage 4, where the ventricles are hypertrophying, and the patient is disabled here. They cannot do anything. And the same thing is stage A, when the patient is high risk, basically, and then if they start to develop symptoms, and then so the symptoms become mild or moderate, or eventually the symptoms become severe, that's when the patient is, again, in severe symptoms. So again, stage A is not as bad as B, and D is the worst, okay? So just have an idea that the more advanced the stage, the more serious the symptoms. Okay, now we understand the pathophysiology, we understand the physical exam, we understand what kind of subjective data the patient may share. Now let's see how, as far as diagnostic evaluation, how can we find out? Now, again, heart failure mainly decreases the cardiac output, whether from the right side or the left side. Now, this decrease in the cardiac output has a direct effect on the heart, whether it's compensation or deprivation. So remember that ANP and BNP, they will increase or will be released whenever the ventricles are stretched, whenever the ventricles are under great pressure, and again, increase the production or release of ANP and PNP indicates that the ventricles are struggling. It indicates that the heart failure is we have a poor prognosis. It's a bad thing, because the BNP and NP are released to relax the ventricles and relax the blood vessels, because There's so much work, there's overload on the heart. In ECG, again, we may see some changes. ECG, as you know, basically it detects the electrical activity of the heart. So changes in the heart shape and changes in the contractility as a result of the weakness of the heart will also show some difference or some changes on the ECG. The heart, we can see the structure of the heart on chest x-ray. So if there's a heart cardiomegaly, if the heart become larger than normal because of hypertrophy, we can also see that in chest x-ray. The echocardiogram, as you remember, it's a procedure that uses ultrasound where you can visualize the structure of the heart. You can measure the pressure inside the ventricles and the atrium. You can measure the size of these chambers and give us a lot of good information in this case. Also, this is the procedure where we can measure the ejection fraction. So echocardiogram and heart failure, these are essential. They go together. Now, if the patients could develop chest pain and we're suspecting angina, we could do a stress test. Now, depends on the stage of the heart failure. If the patient stage D or stage 4, there's no way the patient can do a stress test, for example. And if the patient comes, and again, it's possible that the patient develop an MI after the heart failure as a result of the overload. So, patient may need to go to a cardiac cath to see if there's any coronary problems. But ANP and BNP, mainly BNP and chest x-ray and echocardiogram are what routinely is ordered. Now, because of this, again, decrease in cardiac output, there are some effects on other system. So in CBC, that's possible. You may see in patients with a chronic heart failure especially. Again, the prolonged decrease of cardiac output will decrease the renal perfusion, and as a result of that renal perfusion, low renal perfusion, the kidneys will stop or will decrease the production of erythropoietin, and that's why it's common to see anemia in patients with heart failure. Again, as a result of the decrease in the perfusion to the kidneys, you may see electrolyte changes, and you may see a declination of the function of the kidneys. In urinalysis, you may see that. Again, it's all related to decrease of the declined function of the kidneys. In ABGs, low oxygenation, pulse oximetry, you'll see again the patient if the patient is not on oxygen, you may see deoxygenation, and in chest X-ray, you may see a pulmonary edema. See the infiltration. And I have every one of them here just a bit more detail. So remember, the A, B, and B, they come from ventricles, and A and B come from the atrium. So when they stretch, they will release the A and B and P and B. These are the normal. We routinely don't order A and P. We go with the P and B because it's really the ventricles that we care about. Normally, the B and B should be below 100 pJ per ml. And so this patient, for example, has 2,000. So anything above 100 is bad. Anything above 500 is even worse. And the higher the number, the worse the condition. The other one, ECG, we may see cardiac arrhythmia again, or axis deviation as a result of increase the size of the ventricles. Chest X-ray, you may see cardiomegaly, see the heart is big or getting bigger. Echocardiogram, again, you can see if there's any abnormalities in the blood in the ventricles, and so on. Okay. Here's why you will see a CBC again. You may see anemia in patient with heart failure. This is why you may see some changes in the electrolytes, and again a creatinine in patient with renal failure. This is why you may see a proteinuria in patient with renal failure, again with heart failure, again because heart failure eventually, if it's not treated, it will lead to renal failure. And this is what you could see in the x-rays. It's a normal chest x-ray. See the heart size here, and you can see the hypertrophy of the heart in this one. And again, this is why you would see abnormal ABGs, again because mainly of the pulmonary edema. And this is why you could see some changes in ECG. Again, it's a deviation of the left side of the heart, especially if there's hypertrophy. We'll talk about that more in. And in echocardiogram, remember what you would see an echocardiogram. And quickly, there are two types of echocardiogram. We have the one that we call the transthoracic, which is the one that you just saw here. Transthoracic means going through the chest. And so this is a non-invasive procedure where basically we use an ultrasound to visualize the heart structure, especially internal heart structure, like the blood valves and so on. So so there's really no special preparation for this kind of procedure, and it's non-invasive. But as you see, the position of the patient, this is the best position of the patient again to be on the left side. So this way the venous return will go directly to the heart, and if there's anything wrong with the left, especially left side of the heart, it will show with this position. Now sometimes, as you see, the transthoracic, you can only see 2D, you can only see the whatever is facing the chest. But if we want to see the back of the heart, we have to go through the esophagus. So we have another one called Transesophageal Echocardiogram, the same idea, but this time we have to go through the nose, back to the throat, to the esophagus, and look at the heart from the back. Now this is, as you see, this is basically invasive procedure, and again, we want to be closer to the heart and to get more structure. Now this is usually you do it if you do a transthoracic and you don't get enough information, so we have to do a transesophageal. Since this is an invasive procedure that will involve numbing the throat of the patients, we need to put the patient in PO for 6 hours before we do the procedure. So we do a conscious sedation. The patient will be in lateral position. We use an endoscopic camera. Usually the test takes about 90 minutes. Again, the patient will be asleep. During that time, we have a continuous monitoring of their vital signs and ECG just to observe for complication. And one of the complication is hypotension and bradycardia. Again, this can be as a result of stimulating the vagus nerve. Okay, and again, we want to monitor the patient after, and then we want to wait for them until they wake up before you can feed them again, assess the gag reflex. Okay, the other thing is ejection fraction. Again, this is an important term when you think of heart failure. You must know that what ejection fraction, what is normal ejection fraction, and how we measure ejection fraction. Again, the way we measure it is through echocardiogram. Normally it's 50% to 70%. Anything below 60% it's considered heart failure. And again, ejection fraction only applies to the systolic heart failure, because during diastolic there's no systole basically. So that's why, again, systolic heart failure, while in the diastolic heart failure you see a normal ejection fraction. Okay. Now, complication of heart failure, again, if we don't slow it down, it could be a pleural effusion. Again, increase the pressure in the pulmonary circulation can lead initially pulmonary edema, but it may also lead to pleural effusion. Dysrhythmia, again, the changes in the structure and the thickness of the walls of the ventricles can lead to dysrhythmia. Some of this dysrhythmia can be lethal. Also, because of the increase in the pressure in the left ventricles especially, which will increase the pressure on the left atrium, that can have the same effect like atrial fibrillation, where patient become at risk for thrombosis. And again, increase in the size of the liver, increase in the size of the spleen, and again, mainly one of the serious complications is renal failure as a result of severely decreased cardiac output that's not compensated. Okay, when we think of the management, we need, again, let's go back and review the symptoms or the pathological symptoms and see how everyone can be treated. Now, for impaired contractility, again, we can use entropic agents like digoxin. Now, this is medication the patient can take home. It's available IV and PO, but dopamine, dobutamine medication, this is if the patient is admitted and usually go to ICU to receive this medication. Now, if if the patient developed cardiomyopathy and now the conducting system is the problem with contractility comes from a conduction system also, we can use pacemaker. The other thing is, again, if the patient is wet, which means they have edema, which could be peripheral or pulmonary, then the drug of choice at this point is Lasix. We have loop diuretics. If the patient has potassium issue, we can use potassium sparing diuretics. And we need to do a fluid restriction and sodium restriction in this case. Again, remember, one of the compensatory mechanism for heart failure to maintain the cardiac output within normal is to increase the sympathetic stimulation. And again, but that doesn't help, so that's why we have to use beta blockers to block that stimulation, because that stimulation just increase the work on the heart, and that can increase the consumption or the need of oxygen, and that will make the demand greater than supply, and patient may actually develop angina as a result of it. Again, we have increase in the afterload and the overload. Remember, the afterload is the resistance that the left ventricle will have to overcome, so it comes from the vasoconstriction of the blood vessels. So that's why we use vasodilators to help that or to treat that, and we have hydrazine and nitroglycerin. And also we can use morphine. Morphine is great because it relaxes both ventricles, so it's actually decrease the preload and the afterload. Now, increasing the preload also can be, this is a result of increased venous return. So we can give medication to inhibit the reabsorption. So remember that one of the mechanisms, again, earlier mechanism is the RAAS. So using ACE inhibitors will prevent that activation of the renin-angiotensin aldosterone system. In fact, this is one of the most important medication now for management of heart failure. ACE inhibitors are one of the most important medications for heart failure, because with the prevention of the activation of the RAAS system, that decrease the venous return, and that's huge. Give a huge help in preventing the change or the hypertrophy of the or remodeling or changing in the structure of the ventricles. ARBs are available in case the patient cannot take the ACE inhibitors, whether because of allergy or because of angioedema or cough. Also, vasodilators can help in decreasing the preload, but vasodilator mainly for the afterload, and also morphine. If the patient developed hypokalemia, we can give potassium supplement. If the patient developed dysrhythmia, we can use dysrhythmia medication. We'll talk about that in the second part of this lecture, class today. And if the patient become at risk for thrombosis, we need to put them anticoagulants, and most commonly we use Coumadin. All this medication were covered before and also in pharm as a cardiovascular medications. But let's just go quickly over them. Diuretics, remember, these are the first line for all patients with fluid overload. The first line is to just get rid of some of these fluids. We have several of this medication, but so we have thiazide. We usually it's the drug of choice. This will help if the patient in early stages and if the patient has a normal renal function. If the patient doesn't have normal renal function, thiazide will not work, and then we'll have to go to the loop diuretics. Now, when the patient comes to the hospital, again, that means that they are decompensating. We usually use Lasix as a first line, but the thiazide is a medication that the patient can take when they go home. But a lot of patients also, they take Lasix, okay? So because Lasix give stronger diuresis. Now, as a result of that, the hypokalemia is a possibility that we have to be careful. Remember, we talked about digoxin before, and digoxin toxicity can become even worse or likely to happen whenever there's hypokalemia. So if the patient has renal failure, we're not going to try diuresis. We have to, our renal insufficiency, we have to go to the loop diuretics. We have the potassium sparing just in case if we have a serious hypokalemia in this patient. So we have to, and we need to spare the potassium. We can use that, but the diuresis from the potassium sparing is not as strong as loop diuretics. So Lasix continue to be the drug of choice in this case. If you spare potassium, you can increase the potassium level. So hyperkalemia is a risk factor in this case. Now, remember, in ACE inhibitors, we said ACE inhibitors are great. Again, they are the cornerstone now of heart failure therapy. They decrease the fluid retention by inhibiting the RAAC again AS, and again they decrease the cardiac remodeling, and that is a great one. And basically that's the theory says that they do, the ACE inhibitors, they do that by increase the kinin. Remember that another side effect or another co-factor or co-process of ACE inhibitors is that kinin level increases, and that's why the patient's coughing, because the body tried to get rid of it through exhalation. But this peptide or this hormone helps in decreasing the remodeling, and that's again preventive remodeling will decrease or slow down the progression of heart failure, so it is a huge benefit. Also, because it's blocking a vasoconstriction around the kidneys, it can improve the renal perfusion. Okay, so it can help the patient also who is at risk for renal failure. It also improves cardiac output by reducing the afterload. Again, reducing afterload is a result of the blocking of vasoconstriction that this system causes, and so it decreases the preload and the pulmonary congestions again by through the vasodilation process. Okay, now again, because of the blockage of that, we decreased the patient may develop hyperkalemia as a result of using ACE inhibitors, because ACE inhibitors will prevent the water reabsorption. Patient also may develop hypotension, again as a result of increased diuresis. Cough, we talked about it as being one of the major side effects of ACE inhibitors. An adverse reaction of ACE inhibitors is angioedema, where you have to quit the medication if the patient develops that, and also this medication, never give it to a patient who is pregnant. Okay, and we talked about that ARBs basically is available just if the patient cannot tolerate ACE inhibitors. Now the beta blockers, and the most common, we use the correct, one of the most common one. Again, this is we don't like to use it unless it's really necessary, but again it's suppressing the extra stimulation that's coming from the sympathetic nervous system, and because that increases the workload on the heart. Now, you remember the digoxin? We talked about digoxin being a positive inotrope and how it works, that it competes with the potassium, and it increases the contractility, but also decreases the heart rate, and that's, you don't give the digoxin if the heart rate below 60. However, if your patient's taking digoxin at home, and ask them, of course, to measure their pulse every time before they take digoxin. We really want them to take digoxin, but if their heart rate is below 60, they should call their physician to see if they should take it or not. But if you're in the hospital, you want to make sure that the pulse is within normal before you can give digoxin. And we talked about digoxin again before. Now the other side, or the other management, or part of management that's really important, is the nutrition. Now, most patients with heart failure, they should get a low sodium diet. Now, how low or how much depends on the severity of their heart failure. But in general, you know, now the relationship between sodium and water. So more sodium means more water reabsorption. That means fluid overload. We should try to, you know, individualize it to increase the adherence of patients. Now, patient with edema, again, the edema is a result of fluid overload. So restriction of, we should teach the patient about some of the restriction, you know, restriction of sodium, for example, how they can alternate, you know, use different food that has less sodium. Now, if a patient has mild heart failure, which will be like a stage 1 or 2, then we recommend a 2.5 gram of sodium. 2.5 gram of sodium in their diet. Now, usually the average American takes about between 5 to 7 gram a day of sodium. So if it's severe, like stage 3 or 4 or C or D, then we need to really cut down on sodium, like 1 gram at the most per day, of course. So right now there's an approach recently, you will learn about that in nutrition next semester, but it's called the DASH, which is the day of 3 approach to stop hypertension. Now it's been effective and it's a first line therapy as far as the nutrition, and it's also used for patients with heart failure. The fluid restrictions is not, now we have a liberal, really we're not that much in the restriction, only in severe heart case like stage D or stage 4, when we want to restrict the fluids usually to 1 liter per day. Big time, very important for this patient to weigh themselves every day. Ask them to do it at the same time. Usually we prefer it just before breakfast so they see what happens during the night. And change in weight is one of the most important symptoms that the heart failure is getting worse. So, and it's the simplest thing that the patient can do every day. So you want to teach the patient, if they gain weight like more than 2 pounds a day or 3 pounds over 2 days, they need to talk to their physician and they might get admitted as a result of that. So weight change more than 2 or 1.5 pounds a day, and they have to report that to their physician. Now here's some of the common nursing diagnoses that you could, as far as nursing management, that you could use based on the pathophysiology of this patient. Again, there's a fluid excess if the patient has edema, whether pulmonary edema or peripheral edema. If the patient has dyspnea as a result of pulmonary edema, you can use impaired gas exchange. If the patient is fatigued and cannot work, do the regular exercise or regular activity, that's activity intolerance. If the patient's, again, there's a indication of being cold and having low perfusion, then you can use decreased cardiac output. And if the patient needs more education in terms of how to manage their symptoms or monitor their symptoms, you can use deficient knowledge. Okay, education is huge for this patient. Again, there are multiple areas that you can educate. You have the medication, you have the nutrition, you have the symptoms, and so on. And so, for example, for diet, again, reinforce that the patient should weigh themselves every day, stay away from the high products that has, the products that has so high salt or sodium and so on. Activity are encouraged. Simply, you tell the patient to exercise or to move as tolerated. And there's a lot of programs that they can join. Now, monitoring, this is very important for this patient. This is important for management of heart failure at home. Patient needs to report any symptoms that indicates that their heart failure is decompensating, and this can include orthopnea, dyspnea, edema, weight change. Any of the symptoms that indicates this is an acute decompensation of heart failure must be reported, and the patient will most likely be admitted as a result of that. So you need to teach your patient how to assess their edema. You need to teach how to recognize that this is dyspnea, and of course to do the weight change every day. So report immediately any of the following. Again, change in weight, difficult breathing, waking up breathless at night. Again, this all are indication of decompensating heart failure, and the patient needs to contact their physician. That's the first thing they do. This is not the symptoms that patient can manage or take extra pill of Lasix. No, we need to, due to the high mortality rate, we need to know what's going on with the patient, and then admission could be the solution. This patient, again, definitely because of they're sick, because of the status of their perfusion and their hemodynamics, we encourage them not to get sick. So taking vaccination is highly encouraged in patients with heart failure, flu yearly, and pneumonia every 5 years. Again, if they have any risk factors or ongoing risk factors, to try to get rid of it, like if they're smoking, to cut down or quit. If they drink alcohol, again, to change that. If they have hypertension, to make sure to control it and manage it, to take their medication and so on. A balance between rest and exercise is crucial. Also, the patient should know what where their limits are, and not to go over that. And as far as medication, we talked about all this kind of medications, and the major one is to teach, for example, of digoxin, and to teach about digoxin toxicity. If the patient is taking antihypertensive medication, to make sure to teach them about the dizziness and all especially the first dose. Vasodilator, big time, keep an eye on the blood pressure, and so on.